platform is open. If you want, you can start. It's on YouTube also.
All right, good.
So, have a nice day. Sorry for.
It's okay. So let's start. Today's pediatric ECG arrhythmia seminars would be English. You know, 1 week we do English, 1 week it's Turkish. If anybody can confirm that you have a good voice and you can see my slides, I can start. Again, use the chat window. All right, let me see. Okay, so you can, good. All right, let's start with the first patient. This is a 15-year-old male patient, and this is the ECG you see. So please tell me what you notice and how you assess this ECG. Okay, I'm waiting for your inputs. It's a 15-year-old patient. I'll give more history later. What is it that you're noticing or anything that's capturing your eye? Pay attention to ST waves. Let me give you a hint. Okay. So the comments are like some T waves are tall. Okay. Any other comments? There's a little bit of a ST elevation. Okay. And there's one comment saying that maybe it's the QT is short. And actually, if you pay attention, this QT is really short. And indeed, that's what you need to suspect in this case. And this 15-year-old actually ended up having short QT syndrome. And as you see, the T wave is a little bit peaked, tall in some leads, but the main thing is really the QT is quite short. This is another ECG on this patient. And this is how the patient actually presented with this rhythm. And the ECGs you show later on, I showed later on, were actually during the sinus rhythm. And so this patient presented in VF. And as you see, so it was a short QT patient. So we always talk about QT intervals. And, you know, we say we have to pay attention. We shouldn't miss long QT. Obviously, long QT is much more frequent compared to short QT syndrome. But we should think about short QT syndrome also. In summary, when, you know, if you have anything less than 360 milliseconds in terms of corrected QT interval, it's a borderline short case. And in addition to, as you know, you may know the guidelines already, but expert guidelines for diagnosis requires less than 360 of QTC interval, plus a pathogenic mutation or family history of short QT or family history of sudden death less than 40, and or survival of a VTVF episode in the absence of other heart disease. So, or if you have really short QT, like less than 330 milliseconds, then you can actually directly, you know, diagnose short QT syndrome. So it can be missed. I mean, you may just think, you know, T wave is tall, there's a little bit ST segment elevation, but even though it's rare, so we need to make sure the QT interval is really not short. Okay, this next case actually is a patient that we just diagnosed as of today, presented to our emergency, and the age is 16 years, history of DTGA repaired with atrial switch operation. So Senning, I believe, of cardiac meds since age of 3, didn't follow up for a while. So 4 years ago, last follow-up was showing some RV dysfunction, and didn't come after that. And this time presents with 5-day history of upper respiratory tract infection and symptom of heart failure. And this is the brief echo image or video. You see how the function is horrible. Okay, parasternal long axis, both ventricles especially systemic one, okay? And this is the ECG. The rate is 135 or so beats per minute. And so with that presentation, what would be your thoughts and what do you think about this ECG? Again, for the ones who are just joining, this is the patient, a new patient with this history, presenting with significant heart failure. And this is the ECG. All right. Sorry for the quality, maybe not perfect, but I had to take picture with my phone today, just before coming to home, actually. This is a new case. So what do you think about the ECG? What are the possibilities? Again, the rate is 136 beats per minute. So I'm waiting for inputs from any of you. Please use the chat window. Yeah. So that's the ECG, again, 12-lead ECG. All right, so any ideas? What could be the case? Okay, one idea is JET, RVH, okay, makes sense. Internal rhythm, again, there's significant heart failure. The rate is 136, so could it be sinus tachycardia? Long QT, another idea, okay. How about in terms of rhythm? So there's one suggestion that it may be JET. I think the reason you mentioned JET is not seeing clear P waves, right? And if you look at the QRSs, there's suggestion of WPW, but if you look at the QRSs, the Q waves are relatively sharp. The onset of the QRS is relatively steep at most of the leads. And actually, I don't think this is WPW. The problem here is, as suggested, it's first of all, it's tachycardia. And secondly, it's relatively narrow, so it's not like VT, right? And we have difficulty seeing P waves. So in such cases, one possibility, of course, can be JET, just without even knowing the ECG. Like if somebody tells you, we have this patient, 16-year-old, post-atrial switch, presented with tachycardia, narrow QRS tachycardia. Obviously, of course, it can be sinus tachycardia, right? But then you need to see P waves, clear P waves, which we don't see here. But sometimes you can have sinus tachycardia that can be misleading if there's underlying first-degree AV block, right? And if they're in tachycardia, and then the P waves may come on the T wave. So that's still a possibility here. If you look here, maybe P wave is right on the T wave, and maybe this is first-degree AV block and sinus tachycardia. Okay, maybe it's JET because I don't see clear-cut, P waves. Since we are talking about P wave can be possibly locating right on the T wave, it can also be potentially focal atrial tachycardia, right? And there's another suggestion saying atrial flutter. Indeed, again, if this is atrial flutter, we don't see clear flutter waves, right? So it cannot be atrial flutter. But I think what you mean with atrial flutter, probably intra-atrial reentrant tachycardia, which is like atrial flutter, but it's not atrial flutter. Atrial flutter is a different rhythm, but it's a macro reentry tachycardia, atrial tachycardia. So we call these scar-related macro reentry, macro reentry atrial tachycardias, intra-atrial reentry tachycardia. These things usually occur following years after surgery, and sending patients can have them also. And usually they don't have like typical flutter waves, but it's like flutter. You can have 1-to-1, 2-to-1, 3-to-1, or whatever variable conduction through the AV nut, and you can miss it easily. So yes, you have to think about flutter or intra-atrial reentry tachycardia. So these are really the main things when there's this type of sinus, this type of actually narrow QRS tachycardia, and when you don't have a clear-cut actually P wave. So to further assess this patient, what should we do? Okay, again, suggestions. That's the story. This is the ECG, and these are some of the possibilities. What is the first thing that you want to do? Adenosine, right? So the reason for adenosine is like if it's flutter or intra-atrial reentrant tachycardia, we may have a response. If it's sinus tachycardia with first-degree AV block, we will actually slow down the rhythm, and even though it's first-degree AV block, we may be able to see like the gradual slowing and gradual acceleration, and the PR interval changes, so we can bring up the P waves. And again, if it's flutter or intra-atrial reentrant tachycardia, you may actually see, like the flutter waves or the extra P waves, and then you can clearly diagnose. Or, if it's jet, you may not have any response, right? Usually jet does not respond to adenosine. So adenosine is helpful. This patient, yes, we did adenosine, 2 doses actually. One was 12 milligram, and he was really coughing and everything. So he already had some pleural effusion, significant orthopnea, so he is in significant heart failure. We didn't want to give any more. We gave 9 milligram, we didn't see any response. We gave 12 milligram, we didn't see any response. So the rhythm was the same, the rate was the same, 135, 136 beats per minute. And we saw that, he was coughing and all that. Maybe the dose was not enough, I don't know. But we saw some effect on the patient with 12 milligram. And he's around 85 kilos. He's a big, teenager. So adenosine didn't help. And because of his significant heart failure and bilateral pleural effusion, limited lung function due to all these things, we didn't want to give more adenosine at that point. So after this point, what is your suggestion? And obviously, on echo, I showed you the function. What is the most important thing besides the function that you want to make sure in this type of patient? Especially with the possibility of flutter type rhythms maybe being there. What is the thing that you really want to rule out in a patient like this? Okay. Suggestions? I'm waiting for any response. What do you want to rule out? Thrombus, right? Because if there's thrombus, and if this patient is in intra-atrial reentrant tachycardia, if you cardiovert this patient, you may lead to stroke. Although, if this patient is in heart failure, like this case, significant heart failure, you don't have too much choices, but at least you can heparinize patient. You can at least make sure there's no big, obvious left-sided thrombus. In this case, left-sided meaning systemic RV side thrombus, or in the systemic side. And then you can cardiovert. So you have to pay attention, make sure there's no obvious thrombus. And that's what we did. While we gave adenosine, and at the same time, just before we repeated the echo, looked carefully, left atrial appendage and all that, there was no obvious thrombus. We didn't do TE, patient was still awake. So no obvious thrombus. So we did adenosine, again, didn't help. So what do you do at this point? We still don't have clear diagnosis. The things we mentioned are all possible still. So what do you suggest in this patient at this point? Any ideas? One suggestion is that we can just go ahead and try cardioversion. Do you have any other questions about the patient? Like you want to have more information to help you? There's something very important that can differentiate. Stress ECG, this patient hardly can sit up. So we cannot do stress test. Okay. All right. One thing that you should have asked, which is very important. This patient actually, heart rate was fixed at 136 beats per minute, 135, 136. It was not 130, never, during the stay several hours in emergency and later in ICU or in the, in the hospital. It was not 140, never. It was not 130. It was around 135, 136 beats per minute. So whenever you see a fixed heart rate in a actually post-congenital disease patient like this one, and if it's tachycardic, you have to think about intra-atrial reentrant tachycardia, or some people call it flutter, which is not the right term, but so you have to suspect micro reentrant tachycardia, and maybe what I am seeing is like if it's like this, the rate 136, maybe atrium is going 270 beats per minute, okay? That would give you a fixed rate. The other thing that would give you really fixed rate like this would be jet. But jet would be quite unusual, right? In terms of the possibilities, it would be quite unusual, but technically it's still possible. So adenosine didn't help, so we didn't know at that point. We wanted to see P waves, basically, right? So we cannot. I doubled the voltage. This is what you see here. The amplitudes are doubled here. I think it's 20 millimeter here, and still I have difficulty seeing any clear P waves. So, and adenosine doesn't help. What we do at that point is actually we did an esophagus ECG. So we insert a catheter through the esophagus and put the V1 lead, attach the lead to the special box, which is an amplifier. And this V1 is attached to the esophagus lead, actually. So pay attention to the other precordials and look at this one. You see these spikes? There's 2 spikes for 1 QRS. There is some irregular rhythm here. At this point, patient was sedated. With sedation, there was irregular, faster rhythm. And indeed, as you see here, there's 2, I can zoom, let me zoom. There is more actually atrial signals than QRS is much more. And actually the rate here was 270 beats per minute. The rate of this AA, 270 beats per minute, so exactly twice of the presentation rate. Here being a little bit faster ventricle is because AV node conduction was faster after ketamine is given. So at that point, we knew our diagnosis. There was no obvious thrombus. Heparin was being given. So while he was sedated, we cardioverted. And again, look at the baseline ECG and look at the ECG after cardioversion. You see nice big P waves and sinus P waves, right? So look at this one before, here. Okay, again, look at this one after. So if you don't have esophagus catheter like this, okay, obviously you don't have much choices, not responding to adenosine, you can still try cardioversion, assuming it could be actually 2-to-1 atrial flutter or intra-atrial reentrant tachycardia. Again, the clue here is fixed heart rate. When I looked at these patients like 1 hour or 2 hour telemetry, it was like a straight line. The heart rate was 136 fixed rate. I knew this was 99% intra-atrial reentrant tachycardia, even before doing esophagus ECG. Actually, when I first saw this ECG, I said this is IART most likely, but I had to prove to be able to do something. So we stopped, and what we did after that, we started amiodarone infusion because right now the function is very bad. This patient, of course, is a candidate for ablation, and heparin should continue, has to be on Coumadin-like anticoagulant for a while, right? This is important because the atrial function does not recover immediately. At least 3 months needs to be on something like that. And at some point we will consider either at this admission or later, ablation. So these are kind of the initial things we are doing. All right, very good. So this is a 3-month-old patient. We are changing the subject. This is the ECG. It's now maybe not very clear, but 1, 2, 3, AVR, AVL, AVF, okay. And these are the precordial leads. So any ideas? Okay, one suggestion is PAC. Another suggestion is flutter again. Okay, well, I mean, if you look at the 3-month-old, it's not too fast, but the baseline is kind of not very clear, right? So you cannot make up a clear P wave. And actually, if you look at AVL, AVF, it makes you suspicious at the end of QRS, after the QRS. Is that negative deflection like similar to the one before the QRS? So, and it changes, you know. You look at different leads. At the end of the QRS, there is some deflection. That's kind of strange for a QRS, right? So you wonder whether this is really flutter or not. So yes, you should be suspicious of flutter or again, intra-atrial tachycardia. This is this patient. Again, you have to look in 12 lead in a better way. We are looking and okay, there are P waves here, but really not very clear. I mean, look at this T wave. Is this a U wave or is it a P wave? Is a inverted P wave? So all these possibilities, right? And looks like the rate is around, you know, 145 maybe beats per minute, something like this. So little strange, clearly not sinus with this. So in this type of patient, I mean, again, like the previous patient, vagal maneuver or adenosine is the thing to do. Actually, sometimes if you have time, like the other patient was in heart failure, so we had to figure out immediately, right? And we didn't want to cardiovert the patient because I don't like to treat patients when I don't know the diagnosis. I could have stopped the arrhythmia with cardioversion, but I would never know this previous patient was in intra-atrial tachycardia or not, right? And then for my future treatment, I wouldn't know what I stopped. Did I stop focal atrial tachycardia? Did I stop, you know, 2-to-1 intra-atrial tachycardia? So it would be nice to know, and that's why we did this esophagus. Here, if you have time, and this patient was not in heart failure, we placed a Holter like this. Again, you know, this really makes you suspicious, right? Now this time, maybe there's something 2-to-1 here. And actually, occasionally during Holter, this patient has variable AV conduction, and the P waves actually come out. And yes, and now you can tell this patient actually in intra-atrial tachycardia, right? With these additional P waves. So sometimes if the patient, you know, sometimes you diagnose during actually Holter, and especially you need to look at the Holter when, you know, the rate is slowing down, if you can find these areas. This was also a setting. So the first patient was a 16-year-old, right? This one is a 3-month-old operated setting. So you can have these problems even short after surgery. But most of the time we see these problems, you know, years after surgery. And one important note in this patient is this patient's actually telemetry or the Holter trend. You should always pay attention to Holter trend. You see around 150, there's kind of a fixed heart rate, but it's not that fixed, it's variable. And this variability here is due to variable conduction like you see here. Not because it's like sinus variable. You see some flat segments and then you see some slower areas. So this patient actually presented with this, therefore the rate, as you see here, is like double of the rate here, right? So the rate actually 145, the QRS rate, the presentation rate. But you know, this patient presented with this operated setting, unknown duration of arrhythmia. The referral center told us that the patient had SVT with 280 beats per minute. They started propranolol and the SVT stopped. There was no thrombus, the function was normal. So the red line, what do you think about the red line? Later, arrhythmia stopped, and patient was sent to us on propranolol. And I showed you the rhythms from our Holter. So what do you think the problem was? Initial presentation was SVT with 280 beats per minute. This 3-month-old SVT stopped, and they sent the patient to us, and I showed you the Holter. So what do you think the problem is? Okay, anybody please? Okay, let me help you. The problem was the SVT never stopped. It just became, you know, 280. Why 280? Because you see, the rate is 280 in the atrium. So this patient was conducting apparently 1-to-1, and after they started propranolol, it became like here, 2-to-1, and you can look at the trend again. So most of the time 2-to-1, sometimes 3-to-1, 4-to-1, like irregular, like this. So they thought the patient converted actually. So there's no AV block. This is normal physiological AV block during flutter or intra-atrial reentrant tachycardia. There's no AV nodal dysfunction. These fast arrhythmias actually a lot of times present with 2-to-1, 3-to-1 conduction or variable conduction like here. So initially it was 1-to-1, and actually beta blocker made it 2-to-1, and they thought they stopped the arrhythmia. They didn't. And the risk here again, like the first patient, if you miss intra-atrial tachycardia in a patient, reentrant tachycardia, IART in a patient, if you miss flutter, if you miss fibrillation, and if duration is more than 48 hours, and especially like several days or more, there is risk of thrombus, thromboembolism, and stroke. And these type of rhythms can be missed, like in this patient also. So here is another example of, kind of subtle IART. So basically it didn't stop. And actually when we further look into the Holter, there's even like these areas in this patient during the vagal events, during the Holter. We have pauses after 5 seconds. And this is all vagal actually. There was no real AV nodal dysfunction actually. All right, so this patient's Holter basically confirmed what we had. We didn't need to give actually adenosine in this case. But if it didn't help, we would do it. Okay, so we switch to next patient. What do you think about this? Not much, right? Okay, this is a Holter. Okay, now this is later part of the Holter. We are looking at the Holter of the same patient and something changes. So what does change? What is it that's changing? Anybody? P wave, inverted T wave, okay. How about QRS? Look at the QRS. Totally different, right? Okay. So there's a significant change in the QRS. So this is before, after. Even the P wave, I agree, changed. So what do you think happened here? Any ideas? We see a significant change in QRS, and even the P wave is a little different. Okay, possibilities: accessory pathway, focal atrial tachycardia. Any other possibilities? One of my first fellows from Medipol, Hajar, I need to mention your name. Sorry, thank you very much. She's taking care of cardiac ICU patients now at a large center in Istanbul. She was one of my first fellows at my previous institution in Istanbul. And she says maybe the leads actually changed. Yes, and that's the answer because she has seen those number of times with us. So when you see a change like this significant, you need to make sure that the leads didn't come off and they didn't put it in another area. We see this very commonly, and it can really confuse us, okay? So actually, if you look at these areas, there are some blank areas. What happens when the lead is out, the patients put it in a slightly different area and the QRS may change. And as you see here, before and after, the family actually puts the lead in a different position and the whole QRS change, and you can basically confirm it by looking at before and after. I just showed this, just like an artifact, you have to actually be careful about the changes in the Holter. You have to make sure it's not because of lead change. All right, we switched to another patient. As you see, initial part is sinus rhythm, and later we see some pacing. So what type of pacing do you think we have? What type of pacemaker do you think we have? Yes. Any ideas? Is a single chamber pacemaker, dual chamber? It's atrial, dual chamber, ventricular, atrial, which one? Initial part, we don't see first degree AV block, right? We see normal sinus rhythm. Suddenly we start to see some pacing. Okay. Some people say no pace, some people say single V. Actually, if you see the blue spikes annotating the atrial spike, basically in this case. Why? Because after the spike, you see a P wave. And if you look at the duration below, it's about 1000 millisecond, right? So what's happening here, actually, the patient is sinus rhythm, and then the sinus stops, and the pacemaker, which is pacing atrially, so there's atrial pacing here due to sinus bradycardia. And let me zoom. Yeah. Okay. As you see, 1000 millisecond. Look below. The pacing spike belongs to P wave, not to QRS. Actually, the QRS is the same as baseline. So there's no pacing with the QRS. If there was pacing with the QRS, what would happen? The QRS will change, right, compared to sinus. So what you see here is only atrial pacing, and PR interval is the same. And if you pay attention, look at the P waves in sinus versus pacing. Of course, it's different, right? It gives you a different P wave morphology. All right. So there's atrial pacing here. And then next slide of the same patient shows us the trend. Whenever you see a trend like this is not physiological. There's a low limit, which is like a flat line, tells you that there's a pacemaker. And you see it's set at 60 beats per minute. That's why the patient is pacing at 60. Lower rate is 60. So in this patient, again, continuing to apace, like here, this is the baseline QRS, and suddenly here the QRS changes, right? And then goes back to the pace again, and there's another different QRS. So what do you think happening here? Why the QRS is different? There's atrial pacing spike or pacing spike. So what is happening with this pacing spike? Any ideas? This morphology again is different. Look at the QRS is significantly different, especially lead one actually. Same here, there's another one here. So what's happening here? Okay, one suggestion is, could it be accessory pathway? Okay, any other suggestions? Okay, not much. So could it be accessory pathway? Well, for accessory pathway, you have to have short PR and wide QRS, which, you know, by definition could be. But here, if you notice 1000 millisecond, so you basically have the same atrial pacing. The P wave starts, but before the P wave is ending, so there's no PR interval here. You know, the P is cut basically in the middle, and the QRS starts. So there's no conduction here. Look at the P wave here before. This is the same P wave being generated. In the middle of it, QRS starts. So there's no PR interval to lead to accessory pathway conduction. So it's not pre-excitation. Basically, the QRS is starting same time as the P wave. There's no conduction here of the P wave down the AV node, because look at normally what the AV conduction is on this patient. Here, there's no AV conduction. There's not even a P wave. Only first half of the P wave is seen. So therefore, both P and QRS come the same time, but they are not related to each other. Then what is this QRS, if that's the case? Is it junctional, as suggested by one of you? Is it ventricular pacing? If it was ventricular pacing, right, you may not always see the spike. You should have had a normal AV interval. Here, there's no AV interval. There's atrial pacing immediately after you have QRS. So it's not actual ventricular pacing. Could it be junctional? It could have been junctional escape if the QRS was the same, right? You see, the QRS is totally different. So therefore, and this is not conducted, same thing here, same QRS, it's different than the baseline QRS. So any QRS that's different than the sinus conducted QRS, like this, actually is ventricular. So what we see here is a ventricular escape. Basically what's happening, this patient is pacing at 1000 millisecond, and then there's a delay, slight, actually, let's look at from beginning. There's 1000 millisecond. The second one again, the third one comes at 1000 millisecond. The same time, for some reason, you have a ventricular, you can call it escape. It's too late to call it really PVC, and same thing here. So they come about the same time as a pace QRS, okay? Good. So this next patient is a 24-year-old, and this is the ECG. Okay, waiting for your input. What do you think could be going on with this 24-year-old? Okay, one suggestion is that the voltages are too low, right? Too low voltages. Okay, good. What else? Could the QT be long? Maybe, but you know, I have difficulty seeing T waves except for V2 maybe, and you need to calculate, I'm not sure. But really, main thing really catches the eye is very low voltage, right? Throughout the leads. But about the T waves, more than, okay, one question is, do we know what voltage? You know, I'm showing you this. So it's normal, 10 millimeter, right? And 25 speed. So it's a standard way. So the voltages are, as you see. So we didn't make it less, actually. And yes, the T wave is difficult to see, very abnormal, and you know they are inverted, like in 1, 2, 3, 4, and low voltages. So whenever you see somebody with low voltage QRSs, abnormal T waves, T wave inversions in precordials, especially right precordials, what diagnosis you should think of? Very low voltages. Okay, is it better now? One suggestion is effusion. Pericardial effusion may do that. Yes, it can. But you know, I wouldn't be showing you pericardial effusion here, right? I mean, we are doing pediatric EP seminar. So low voltages, not heart block, because there's normal conduction here. You see the P waves, okay? The P waves are conducting normally. It's just the QRSs are like so small. Dehydration, one suggestion, okay? Any disease, any EP-related disease, let me put it this way. Myocarditis, okay, can be, yes. Cardiomyopathy, you're coming close, very close actually. Cardiomyopathy, which type? There's a specific one. Inverted T waves in V1 to V4, low voltages, should remind you ARVC, arrhythmogenic right ventricular dysplasia, okay? So this patient had that actually. So in ARVC, you should suspect when there is like arrhythmias, ventricular arrhythmias, especially with left bundle branch block morphology. And you should look at the T waves, especially T wave inversion in adults beyond V1, even in children up to V4 is abnormal. And that's one of the minor actually criteria. You can have actually epsilon waves at the end of the QRS like shown here. All right, but especially T wave inversion, low voltages are common. Right ventricular or right precordial QRS is being wider, as noted here, V1 plus V2 plus V3 is longer than V4, V5, V6 addition by a 1 to 2, by a ratio of 1 to 2. So all these things are like subtle but important findings that can happen in actually ARVC. So we have to think about ARVC when we see such patients. Okay, this next patient is actually apparently in a rhythm like shown here, and it's quite fast, right? Looks like, what is it? Maybe 260 beats per minute. So what is the first impression about this ECG? What should you call this ECG first? whenever somebody shows you this, you should call it white QRS tachycardia, right? All right, so you shouldn't call it VT, you shouldn't call it SVT this, SVT that. But specifically, again, the prize goes to Hajar. I'm sorry, I'm proud of my fellow. So Hajar, actually, she's doing CIC. She's not doing EP right now, but this is very good. She said, this looks like Mahaim tachycardia, and she's right. So whenever you see a white QRS tachycardia like this, specifically with a little bit of a left bundle branch block, like look at the V5, like kind of positive. The right precordials are negative QRSs, okay? And superior axis, meaning 2, 3 AVF negative, like this, okay? Like you see. So left bundle branch block, superior axis should remind you possibility of actually Mahaim. And this patient was given verapamil, and they stopped the arrhythmia with that. And actual patient had Mahaim tachycardia. Here's another example. Again, it's not very clear maybe, but this one also left bundle branch block and superior axis. No, it's not actually. Let me see. Where is the V1? No, okay, V1 is here. Sorry, even I'm having difficulty seeing. This patient, look at V1, this time is not left bundle, right? This is right bundle, okay? V1, V2, V3, and then it becomes kind of negative V4, V5, V6, but it's right bundle morphology. And if you look at the inferior leads, let me zoom, 2 negative, 3 negative, AVF negative. So again, superior axis, like unlike the previous one, which had left bundle branch block, here it's more like right bundle branch block, okay? So the first one had left bundle branch block morphology, was coming from right side. It was a Mahaim tachycardia. It's an antidromic SVT using a decremental pathway on the right side. But here, this is a right bundle. And actually, this is also kind of typical. Whenever you see right bundle, relatively narrow looking white QRS tachycardia with superior axis. This is also one of the common types of VT seen in children. It's called left posterior fascicular VT. We can have anterior fascicular. This is LV actually. This is left bundle, posterior and anterior fascicle. You can be having actually VT around this or around that. If you have the VT here, then it leads to superior axis. If you have VT here, it leads to inferior axis. So left posterior fascicular VT, it was the diagnosis here because of, again, right bundle coming from the left ventricle. Since it's coming from the lower part of the septum, it's leading to superior QRS. So 2, 3 AVF is actually negative. So it's kind of very typical. If it was left anterior fascicular VT, it would be right bundle, and the QRSs in inferior leads would be positive. So it would be then inferior axis. Okay, so it's 9:03. It's been 45 minutes. So we are concluding here. I think we will give some Ramadan break, and then probably, I hope, inshallah, we'll convene after that. So thank you for joining, and take care. Have a nice time until I see you next time, inshallah. Okay, take care. Bye-bye.